español, ¿no?
Sí, perfecto.
Porque me preguntan y yo
Ike, bang and gut. That's
What's that?
Bang. I perform bang and gut. That's.
Oh yeah, bang.
Yes, those are cost-effective ways to
Yes.
open up the angle. Yes, good point. So you're banging and you're gadding. Man, you are like a stud.
Hola Álvaro.
Chief,
Hola, Majo, ¿cómo están?
¿Qué tal? ¿Cómo estás?
Bien, bien, ¿ustedes?
Todo bien.
Ooh, Alvaro looks like a boss. So, Maria, we were going to present, we each have like, 10 minutes or so of presentations and a number of videos, and then we will have some discussion. I know my fellows are going to present. I may interrupt them during the presentation a little bit just to kind of add some pearls. And we definitely would like you all to ask questions as well. So we'll watch the chat box and we'll take questions from you as well. And we have special treat. Valentina is going to present in Spanish. Okay. And Valentina and Tiziana, I mean, would you be better speaking in Portuguese for this?
Perhaps. I think I set in my mind already for English, so.
Hey, Sophie.
And we have Sophie here. Say hello.
Hello. Hello, Sophie.
Okay, make your appearance now.
I think that people can understand better English than Portuguese.
Yeah.
Portuguese is like, I don't know why Brazil's Portuguese out of everyone. It's just, if there's one thing I could reverse in history and go back in time, I would make Brazil speak Spanish because it's too complicated with Portuguese, really. I'm kidding. I love Brazil. I'm kidding. Okay, so I'll leave it to you, Maria. I think we're all here.
Well,
Let's start.
we can start now. Rosario.
Dale, empezamos entonces.
En español.
Hago un saludo en español. Sí, buenas tardes. Bueno, bienvenidos a todos. Tenemos nuevamente otro webinar de la Sociedad Uruguaya de Glaucoma. En este caso, María José nos organizó un precioso webinar con Ike y su equipo. Muchas gracias. Y la idea es poner la MICS, el rol de las MICS en nuestro esquema de tratamiento de glaucoma. Thank you, Ike, and your team for sharing your experience with us. Las preguntas que tengan, así sean en español, las escriben por favor en el chat, ya sea el chat de YouTube o este chat, escríbanlas y nosotros en todo caso las traducimos para ustedes. Que quiera las puede escribir directamente en inglés. Bueno, Majo.
Well, thank you very much. Today is it's a very special webinar for us. We have Ike Ahmed from Toronto and his team, Valentina, Tiziana, Deb, Ala. Thank you very much for being here with us. They will share with us some concepts about MICS and tips to start performing this surgery. So when you want, you can start.
Well, thank you, Maria, and everybody here for inviting us. I see many friends in Uruguay. I know Uruguay is not a huge country, but I know that you have great football players, and you have really great ophthalmologists as well. And I had the pleasure of knowing a few of you over the years. Some of you have visited as well, so it's nice to be visiting with you virtually. And when Maria asked me to present something on learning MIG surgery, learning angle surgery, and learning angle surgery that can be applied anywhere in the world, I thought that no better place to start but to have international collaboration with my fellows to present, because they have learned and they are learning still. I'm learning still, but they're learning as well. And they can present their pearls, and they also practice from all over the world, right? We have Tiziana Di Francesco, who's from Brazil. We have Valentina Lozano, who's from Chile, and is really now US and Canadian adopted, so to speak. We have Ala Mufti, who's from Saudi Arabia, and we have Jeb Ong, who is from, I don't know where he's from yet. We're not sure yet where he's from, but he represents our Asian connection. So we have a nice group that everyone's pretty casual here, so please ask questions. And I'm just gonna start off just really talking about really introducing the concept of MIGS and just kind of letting the process start. And again, we are going to speak to this, and I hope you don't mind, but from a really basic level. We don't want to make it too deep, but we want to take questions as well as we go forward. So I hope you can see my slides. If you can't, then yell at me and tell me if I can't. If you can't, but I will start off about just, the concepts. And these are my disclosures. This is Toronto at night. Our beloved CN Tower is probably the only attraction we have here other than Prism Institute. I'm kidding. So I just want to make a couple of really broad points. You've heard me speak about this before, but just remember about one of the things we do whenever we select therapy is thinking about why we do things. And the reason I'm saying this is because too often we focus on IOP and not about the quality of life. And there's one thing I think that MIGS addresses is trying to address quality of life. It may not lower pressure as much as trabeculectomy. We agree on that. But to address things like this, dealing with medications, dealing with side effects that affect the appearance of the eye. And we know from various studies that medications, as good as they are at lowering IOP, they cause many side effects on the eye. And I want to get to the surgical technique, but it would not be appropriate to talk about the technique if we didn't talk about the rationale first. And although you may not think about surgery in these patients who are already on medications and who may be controlled, you think about surgery for those that their pressures are very high, that are progressing. And yes, there's a role for MIGS there too, yes. But there's also a role for these patients that are not doing as well as we'd like them to be because they're not tolerating the medications as well. And if they even are tolerating it, if they can tolerate it, they may not be taking it. And compliance, as we know, is a particular problem. And if we rely on patients to tell us how compliant they are or how well they're doing with their drops, the reality is they don't appreciate, or we don't appreciate, how poor the drops are getting into patients, and they're not remembering, they're not putting in right. And if we ask patients, not that they're lying, but they don't necessarily, they're unaware of how big the problem is. And when they are unaware and they're not compliant, people get worse. So that's kind of the rationale behind MIGS. And I want to make sure we differentiate patients who are, really early in disease, mild to moderate patients versus patients with advanced. Now, for the most part, we'd argue that, MIGS is not necessarily specific to patients who are in this group. This is not going to be the patient that you typically start with MIGS. On the other hand, patients who are, not severe, who aren't rapidly progressing, whose pressures maybe are not best controlled or who maybe aren't compliant, like that's where I think at least we should be thinking about MIGS, particularly when we're combining with cataract surgery. And that's clearly the concept behind interventional glaucoma, or IG, where really we're addressing pressure to get them better by meaning lower, earlier, safer, and doing it with a way to address adherence. Now, MIGS doesn't always lower pressure as low as we want to get it. So that is one of the difficulties with MIGS, I guess you could say. But again, that's why it's patient selection in terms of determining the right patient. Because usually when we get efficacy, we lose safety. And when we get safety, we lose efficacy. And when you pick a procedure, I think we have to determine this. Don't get me wrong. We do a lot of bleb surgery. In my practice, I think we probably do more bleb surgery than do angle surgery because my practice is skewed toward difficult, complicated patients with advanced glaucoma that are progressing. But MIGS still has a role, and those roles are based on the characteristics of MIGS, which is, again, I want to emphasize, is safety. Safety is big, and recovery is big as well. And we don't have a bleb. We know we can take advantage of this. And so we're going to focus on MIGS, and we're going to focus on the canal itself. Suprachoroidal space, we don't have options yet available. SiPass is out of the market. But we are going to focus on the canal, which to me is really the safest place. And this is, again, where we typically think of target pressures. I think it's reasonable to think MIGS can lower pressure into the mid to high teens. Sometimes we can get lower, sometimes we don't get this low, but on average, if we look at most of the studies, that's typically what we see. Mid-teens and often designed to replace medications. So we're not going to go through all these options here, but sorry, I'm talking in this video here.
To inside the trabecular meshwork.
Share with you that there are a variety of
tip is inserted through the trabecular meshwork into the canal,
cutting approaches,
and the filament is then advanced forward here.
And also stenting approaches. And so, as Guillermo mentioned earlier, of course, some of these devices are costly. They're hard to acquire for patients. So obviously, cutting approaches have become universally more applicable. Doesn't mean that they're better necessarily. It doesn't mean that they're less complicated, but I think that there are benefits with access. We have to remember, though, that there are some drawbacks to this space. And although I think we can say they're relatively safe, certainly with stenting, I would say that I feel very comfortable with safety. With trabeculotomies and GAT, there is some risk of bleeding, which is one of the safety issues. We'll talk a bit about that. But other than that, these procedures are quite safe. But we are limited by the level of resistance in the epidural venous system. And this is an advantage because we don't cut hypotony, but we also have potential risks and issues. Let's remember, when we do these procedures we're going to talk about very shortly, we're talking about essentially bypassing the resistance in the trabecular meshwork, which is where the resistance is. We make an assumption, though, and the assumption is that we still have intact distal outflow. What is distal outflow? Well, distal outflow is all the outflow beyond the canal itself. So if I write in pink here, this is basically the proximal outflow system. This is basically Semmes Canal with trabecular meshwork lining it. But if we think about the distal outflow system, we're thinking about all of these aqueous veins, some of these small venous plexus coming off of the canal, and all of these drain into our vena cava eventually, of course, supraophthalmic vein, vena cava, et cetera, et cetera. So we assume that everything in green is intact, but that's an assumption that probably isn't always true, unfortunately, and we don't have a good way to necessarily know that. Remember the anatomy as well. The anatomy is really important. If there's one slide I want you to pay attention on this presentation, I want you to watch this slide here, because what I'm showing here essentially is basically looking at the distal outflow system in more detail. Here I'm showing an example where we have aqueous veins coming off the canal. In any eye, we typically only have 3 or 4 of these veins. The rest of the collector channels are draining into plexus, which are high resistance. If we have the opportunity to be able to get aqueous into the outflow system, we prefer to get into these veins because the resistance is much lower here. If we get aqueous here, we'll lower pressure, but the resistance is going to be higher in the plexus and therefore may not lower pressure as much. Here's an example of this vein. It's hard to see, but you can see this clear vein coming off the canal. There's only 3 or 4 of them. It's a misconception to think that these veins are all over the place, and to identify these is what we think is important. We do know that these veins typically are more commonly found infranasal. So just remember that point, infranasal, because infranasal, I think, if we had to choose one place to go to place a stent or to do an otomy or a cut, it would be in the infranasal quadrant. Because aqueous is typically segmental, it only goes through a certain area of the canal at once. Now, questions will come up. How much of an otomy do you need to make? When we do GAT, do we need to do 360 or not? Well, the theoretical evidence is that no, you do not need to do 360 to get the same pressure control. And why is that? Because we have a certain plateauing of the outflow resistance once we get past 4 o'clock hours. So once you get past 4 o'clock hours, basically the resistance plateaus. Why is that? Because essentially a couple of reasons. One, aqueous is typically segmentally flowing out of the eye, not everywhere at one time, right? So it can't take advantage of 360. And number 2, once you get past the aqueous trabecular meshwork conventional outflow, basically the resistance in the system is what's going to limit it, which is basically the distal outflow system. So for both those reasons, at least theoretically, we may not need to do a full 360. However, location may be important, as I said earlier. Here's a diagram. We're going to talk about 180 versus 360. What I recommend is the following. For example, when we make our main incision, this is sitting temporal. So we're sitting here, surgeon's view here. And we're basically making a main incision here, present temporal. You can, if you do 360, it doesn't matter where you make your goniotomy. It can be anywhere, right? Because you're going to go 360 all the way around. And I can't get my cursor here anymore. Hopefully you can see it. Here we go. So you can make your goniotomy anywhere, right? But so most people go across and make the goniotomy here, 180 degrees away from your TM, from your incision. That's the easiest place to make it, yes. But then you're going to be limited if you're doing 180 to only do 180, for example, either superiorly, okay, if you choose superior, or to go inferior if you choose inferior, right? And the advantage of superior, although we'll talk about, And there's some advantage to going inferior. We'll talk about that as well. Inferiorly, of course, the advantage is you take advantage of the likelihood of hitting these significant aqueous veins. But the disadvantage is if you get bleeding, you're going to have blood settling down here, and it's going to block the otomy you made, and that can defeat the purpose of the synechia. So the advantage of going superiorly is that you avoid hyphemus from blocking the otomy, but you don't get the advantage of getting access to the infranasal side. So to me, the best compromise is to go and make your goniotomy infranasally, and then do a supranasal and nasal otomy. So now you get 180, and you still access the inferior area, okay? But if it bleeds, the blood's going to end up here, and you still have this otomy still open, okay? And then therefore, you still can have a happy patient. Sorry, I had to make that little drawing. So I'm going to just basically leave it at that for you to think about, and I'll let my colleagues talk a bit more about what to do. Allah, I think you're going to talk about whether to do things before or after, but I have a strong preference to do these procedures before phaco if you're combining it for all of these reasons. We can talk a bit about that later. Some people like to do it after. Okay, so I'm going to stop my share there, and I'm going to let Tiziana go next. Make sure, Tiziana, when you do the video, to select optimize for screen share for videos, right? So it'll play a little smoother for you.
You're on mute, TC.
Okay, you're able to hear me now? Can you see my screen?
Mm-hmm.
Yes.
Everything's perfect.
Okay, that's good.
We have your presenter view though.
Yeah.
Ah, okay, hold on.
And again, I encourage all of you to ask questions. I mean, that was more of a background, but you're going to hear really detailed discussions. And I think that too often we get right into the discussion about doing the technique. But the reality is, as Tissi's going to speak about, it's really about visualization. And those of you who haven't done these procedures in the OR yet, this is so important to get visualization right. And Tissi, I think you're still, there you go. Perfect. Okay, so, and this is going to start the meeting. So Tissi, if you can talk to us about the importance of visualization. Sorry, Miguel.
Are you using 3D for the glaucoma?
Yes, we are. We are. I don't know if I say it's better, but certainly it's easier on your body position.
Yes, not just for cataract, but for glaucoma too.
Everything. Not routinely, I'm saying. Some days we do, some days we don't.
And for you, it's a good thing.
I'm just still evaluating it. I wouldn't say it's necessarily the best. Some of our fellows hate it.
Yes.
Some of our fellows like it. I'll use anything.
Yes. Okay. You know some delay when you are working?
No, that's not a problem anymore.
No, this is not the problem. Not delay.
No.
Okay.
The lag is like imperceivable.
For recording surgery, I think it's a very good tool. But
are you using it, Miguel?
Not yet.
Okay.
I'm do retina, so for the retina, it's a very good thing. It's more useful, I think. But I would like to know if you are using for glaucoma too. Yeah. I tried on cataract and I feel well, but not for glaucoma.
Okay, well, Tissi, I think you have the floor is yours.
Okay, so let's talk a little bit about the intraop gonioscopy. The good, the bad, and the ugly. You guys are gonna see everything of fellows learning. So I'll show you how it's real life in the beginning. And I have no disclosures with this presentation. So I see MIGS. I think I see that the success of MIGS depends mostly of your ability to perform a good intraop gonioscopy. So I think one of the most difficult things of MIGS is to be able to have a good view and also to maintain this good view for the whole surgery. And so taking this into account, let's discuss a little bit how we should do when you're learning, how we should, the steps that you need to make to get a better intraop gonioscopy. And I think the first step is choose the correct patient. If you're learning, choose a patient that is cooperative, a patient that is able to turn his head 30 to 40 degrees properly, a patient that is not too anxious or that the patient doesn't have nystagmus. And if you think that the patient is not going to be able to tolerate, you maybe can consider other type of anesthesia that is not topical, but usually the most of the cases we're doing topical anesthesia. And also it's very important to have a good angle visualization at the office in the pre-op. So you're already going to the surgery prepared to what you're gonna find in the angle. If the angle is wide open, how is the pigmentation? And here you're gonna show how important it is to be prepared before the surgery. So like in this case of this video, this patient had a light TM pigmentation, and then we decided to use the trypan blue we inject trypan blue in the AC to then we're going to be able to visualize the TM better. So you can see that it's an easy thing. Like I just put it and wait 30 seconds before you wash out, and you already have this good view. And I think it's pretty good for the ones who is learning, and also especially if you have a light pigmentation. I think it makes your work much easier. And we're gonna talk a little bit about the surgical gonio lens. Regarding the surgical gonio lens, we have the direct gonio lens and the indirect. And here is one of the lenses that we use the most to do the mix. That is the Swan-Jacob lens, that is a direct lens. So for this kind of direct lens, we need to tilt the patient's head, otherwise we're not gonna be able to see the angle. So here's the Swan-Jacob lens, and here's the Cope lens. And there's also the lens that is the indirect gonio lens. Here's the single-use one mirror gonio lens. We use a lot to perform goniosynechalisis, Zen. And here's the lens of our boss, just doing some marketing. No, I'm joking. It's just it's an amazing lens. I hope one day I'll be able to buy. It's a Ahmed DVX lens. It's a 2-mirror lens. It's a very good lens also to perform like MIGS in general, but specifically for goniosynechalisis, I think it's a lens that helps you a lot, because you don't need to go out of the eye to turn the lens at 360 degrees. So it makes your surgery much faster. And also the good thing about this lens is that the direction that you're looking is exactly the direction of the angle, because it's a 2-mirror lens. So this is also makes your makes your surgery a little bit easier. So here there's some characteristics that the gonio lens should provide. So a good gonio lens should provide a good globe stability. You should have a simultaneous viewing. You should be able to get a good view of the angle, and at the same time you should be able to use the forceps and the MIGS device under the gonio lens and still have a good view. The lens should provide a good quality and no decimal folds. And when we're talking about MIGS surgery, you have to develop a skill that is totally different of cataract surgery and traditional glaucoma surgery. So you can see just look into the photo is like completely different. The patient's head, the surgeon position, the hands, the surgeon hands position. So the patient's head usually is going to be rotate 30 to 45 degrees away from the surgeon. Here's like the patient's nose. And the microscope is going to be tilted 30 to 45 degrees towards the surgeon. And also, I'm not sure if you're able to see in this photo, but usually the surgeon's elbow is more far from the body. So your arm is going to be more extended. So it's different from the phaco that you do surgery with the patient pretty close to you. So with the MIGS, usually this makes a little bit different. And with your non-dominant hand, you're going to be holding the gonio lens. Here I'm holding a Swan-Jacob lens. And with the dominant lens, you're going to hold the MIGS injector that I was here holding the iStent G1. And I will share some helpful tips that may look like super easy or super simple, but I think just gonna kind of, if you're not following them, you can have like a easy case turn into a very hard case, and even it can be a very, very hard case that you're not even able to finish if you're not Ike Ahmed. Okay. So regarding intra-op gonioscopy, how we're gonna make our work easier. So when you're placing your incisions, you have to place a directional incision towards the target angle. I will show some videos explaining each tips. Also, when you're doing your incision, you should avoid the limbo vessels, because otherwise you have a lot of blood over your cornea. This is gonna block your view. It's gonna make your view. You're gonna have a poor view. Also, when you're doing your incision, try to do your incision as small as you can, but at the same time, you have to have a size good enough that you're not gonna have a stria when you're manipulating the instruments for the incision. And if you have blood in AAC during the procedure, use your viscoelastic conscious. So like when you're using, try to push the blood away from the area that you're gonna work on. And here I'm gonna show a video how to make a directional incision, just an example. Here I'm doing a GAT, and when you're doing a paracentesis on the cataract surgery, we usually do radial, like towards the pointing to the center of the eye. And because we're gonna start doing the goniotomy in the nasal angle, my paracentesis incision is a totally directed nasal. And here's my temporal incision, also directed to the nasal angle. And now you're gonna see how this is gonna make my life much easier. When I'm inserting the 5-0 proline, and the proline is gonna be much closer to the nasal angle. If I would perform the incision pointing to the central part of the eye, the proline incision, the proline suture would be much far from the nasal angle, and this would make my work harder during the surgery, as you guys gonna see after in the GAT videos. And this video is just a reminder how it's important to have a patient that is cooperative. The surgeon was implanting the Hydrus device, and then the patient started to move his head. It was a woman that she has a dementia, and she was moving a lot. It's common that the patient moves a bit, and this is not a big problem, but this patient was moving a lot. And also the other problem is that the microscope was not in the natural position since the beginning of the surgery. So the surgeon was not able to get the view of the angle back. So by the end, you're gonna see that because of this, we had a small iridodialysis. And in this video, you're gonna see how bad it is to have a blood over your cornea. It's like terrible. It makes an easy surgery to a very hard one. So you have to keep like stopping the surgery, washing the cornea with BSS, and then cleaning the lens. You spend a lot of time. And usually, sometimes, even if you do like an incision more close to the limbus, if you do your mixed procedure kind of in not fast, but in a regular time, you won't have this problem much. But if you spend a lot of time, so you would definitely have this problem. And also here it's a video showing how to use your viscoelastics in a conscious way. So I'm doing the goniotomy to perform the GAT, to perform the trabeculotomy. And I have blood in the AC, and I use my viscoelastic to push the blood away from the area that I'm gonna work on, that is the supratemporal area. And there's one problem that we all have a lot. I think it's one of the most challenging problems that we go through when you're learning MIGS. That is this cornea stria during the MIGS procedure. And this happens usually because of three reasons. The first reason, all the is because the IOP of the IOP is too low, and then you have this stria, or if you're putting too much pressure with the gonial lens over the cornea, or if you have too much tension on the wound. And this is how you can correct. If it's too low, add more OVD, check the incisions, check for wound leakage. And if it's too much pressure, you have to try to don't push too hard. And also for the tension of the wound, you have to relax the tension. And here's a video showing that it's a implantation of a G2 eye stent. I have a pretty good view here. And when I'm starting to place the eye stent, because I'm kind of doing some like, I'm pushing with my dominant hand, the left hand is kind of also pushing over the cornea, like it's a kind of like, it's difficult to have these two movements like coordinating. So this is pretty common. And then because I lost a lot of OVD during this pressure that I was doing over the cornea, before I implant the second eye stent, I went out of the eye, I came out of the eye, I put in more OVD, and then I implanted the second eye stent. And there's also a video I'm implanting G1 eye stent. I had also a good view, and I was starting to insert the eye stent in the Schlemm's canal. And by the end, when I started to have some cornea stria also, because of the tension that I was putting on the wound. So when you're using your incisions, you need to use it. You have to avoid to do like tension in the ends of your wound. So just keep your instruments in the middle of the wound.
Tiziana, I have a question for you from Maria. She asked if you use some methyl cellulose for the external cornea, and if you, how do you avoid the bubble?
Okay, but did she ask if I put it methyl cellulose over the cornea? Is that correct? Yes. Okay, yeah. So we do use sometimes we use a cornea protect that it's a methyl cellulose, or sometimes we use the viscoat. But I think it's much cheaper if you just use methyl cellulose for sure. Yeah. Here usually we already have open the viscoat because of the cataract surgery, so we kind of use a viscoat on the cornea. Yeah, and usually to expand the nasal angle, we use a cohesive viscoelastic. So we use Helan, or we use Provisc.
Okay. And she asked too, if you have a lot of blood in the anterior chamber, you use just Helan, or you can wash it with BSS and then use Helan again?
Actually, I use, if I have, you mean by the end of the surgery or in the middle of the surgery?
In the middle of the surgery, if you have a bleeding, as you show.
So if I have a bleeding in the middle of the surgery, I don't consider much to wash with BSS, because you need to inject something that's going to pressurize the eye. So I usually like to inject OVD, a cohesive viscoelastic, and I try to pressurize the eye as much as I can, and I try to push the blood away from the area that I'm gonna work. So if I'm doing like if I'm inserting the ProLens suture in the superior temporal quadrant, I'm gonna push the blood to the inferior quadrant.
Okay, thank you.
You're welcome. And also, this video is showing how you should work when you're doing the mix without having and avoiding the decimate folds, the cornea stria. So here you can see that I'm holding the gonial lens very, very light. So it's not pushing the cornea, so then I can have a clear view. Even if I'm manipulating the eye, I'm not having decimate folds. And here's the other problem that we have, especially when you're just in the beginning, just learning. It's a top-down view. And it's funny because you have this problem and you don't even realize. So your preceptor is gonna tell you this is top-down view. Your senior fellow is gonna say, hey, it's a top-down view, and you're gonna think that it's amazing. So this happens to me. This was and what I mean top-down view, you're seeing more the iris. You're seeing from the top, so like you're seeing more the iris than the angle. This is one of my first hydras, and I thought was amazing. But you guys are gonna see that it's a very top-down view. Like you're able more to see the iris than the angle. You're not able to see all the angle structures and everything. So you're able to place the device like well properly, but it's much harder, and you have a higher risk to have like a decimate detachment, or you have a higher risk to have complications because you're not having a good view. And here in this video, I was already like able to detect the top-down view, and I was going to perform, if I'm not wrong, it was an eye stent, and then I had a top-down view in the beginning, and I realized that it was the view was not good. Right now it's good, but it's because I'm kind of pushing the patient's eye. So I turned the patient's head more away from me, and then you're gonna check that to the view. It's much better right now. You're able to see all the angle structures and everything. And there's some tips to prevent the top-down view. The first thing, if you have a top-down view, the first thing that I would recommend is to rotate more the patient's head away from the surgeon. The second thing is you can tilt more the microscope towards you. And the third tip is to ask for the patient to look away from you. But the third one, we only ask if we already tried the first and the second one, because then you're gonna depend on how the patient is looking. If the patient moves his eye, you can lose your view. So I would recommend try first the first and the second. If you're not able to, ask for the patient to look away to help you. And this is just a photo when I was doing my previous fellowship back in Brazil. And we didn't have access to MIGS because it was super expensive and everything. But I really wanted to learn how to do intraop gonioscopy. So I grabbed my co-fellow as a patient, and then I performed intraop gonioscopy on him. And that's how I learned. I'm not sure if I learned much, but it was a good experience. And I think there's always a way to learn. Even if you don't have much access to MIGS, you can already try to practice intraop gonioscopy, even in your cataract patients or in your friends or in your co-fellows. And yeah, so that's it. To have a good skill with intraop gonioscopy, it's essential to have success with MIGS and train intraop gonioscopy before starting MIGS. And of course, before training intraop gonioscopy, you need to have a good gonioscopy in the office. So it's just train a lot. Gonioscopy is as many times as you're gonna train, you're gonna be better. And this is what I wanted to share with you.
Someone is asking which type of anesthesia do you use?
We usually use topical anesthesia.
Topical.
Yeah,
Mm-hmm.
it's usually not a problem. The patients they don't feel much pain, and it's pretty easy with that.
Okay, in the first surgeries you did, you used topical also?
Even in the surgery, we already started doing topical anesthesia.
Okay, and another question that I want to ask TC, to avoid bleeding, do you use brimonidine, for example, previous to the surgery itself?
We don't use it, but we use, to dilate the patient, we use phenylephrine. So this also may help. Yeah.
Chrissy, we'll get you to unshare your screen so Jeb can join it while we're answering questions.
Sure.
Okay.
Yeah, so just answer your question, Maria. I mean, brimonidine will help vasoconstriction, but it won't obviously help in terms of reflex bleeding from the canal.
Okay.
And that's going to be really basically a mechanism of resistance, high resistance to low resistance. And if the eye is hypotenuse, we get bleeding back into the AC. So brimonidine, other than lowering pressure, which you're going to be low anyways when you open the eye, it doesn't probably help you. On the other hand, if you're working on conjunctiva, then yes, I think using phenylephrine Ramadi can be helpful on that one. I know that Allah will talk a bit about, you know, bleeding and about contraindications, so I'll leave that for that, but it's a really big point. Probably the biggest challenge people have is on bleeding. And for that reason, and also the visualization, for that reason, I'd like to really overfill the eye with viscoelastic, put more than you need, which is different than when you put stents. But put more than you want in there because number one, you lose some when you go in the incision, and number two, it helps to keep the bleeding minimized. When you do your goniotomy, and again, that's what Allah will say. But there's an advantage because your view also will be better, as Tissy mentioned.
And I want to ask too, if when you do the first goniotomy with the needle, where do you do it? Where is the place, the perfect place to do it? Just in the trabecular meshwork pigmented, or just up?
So I'm gonna let Allah answer that because we're talking about the detailed procedure on GAT next. But it's a good question, very good question. Exactly how do you make the goniotomy? Where do you make it? How do you keep it open? So Allah, be ready for that one. But yeah, that's a good question. I'll let him answer that question there.
Okay, thank you.
So let me get to Jeb maybe. Just Jeb, you want to add a couple points about learning gonioscopy intraoperatively? Because I do believe that this is an area that early surgeons often fail to recognize the importance of. And Tissy's mentioned it, but Jeb, do you want to mention a few points?
Yeah, so I mean, I think Tiziana's already done an excellent job kind of presenting some key concepts to optimize visualization and just success overall when you're doing MIGS, especially as a learner. So I did have just a few points, again, just some few little things that I think could help out even more. One other thing I'd like to mention is that in this fellowship, we get so many Spanish and Portuguese observers that's you start picking up a bit of Spanish. So I just like to say, hola a todos mis amigos uruguayos. Okay, so I don't know if I said that properly. Comment in the chat box below, let me know. So just a few things here that I wanted to mention. This is a very simple thing, but again, why not optimize your view as much as possible? So this is an example of an eye stent that goes in quite nicely. You know, in terms of en face view, this is quite good as well. There's no bubbles, there's no heme or anything like that in the AC. But why not do something such as, sorry, give me a second here. Why not increase your magnification just so that you can really visualize properly? So again, I mean, this goes in pretty smoothly. You got a nice en face view, but you can see how the structures are just a bit more visible because you're a bit more magnified as well. So that's a very small point, but again, why not optimize your view as much as possible? So this next point here, again, TC's already done a very nice job kind of explaining this, but I would just like to mention that when you look at the Decimase folds, when you're performing this, they can kind of give you an idea of what exactly is the issue. She did a great job of kind of explaining how sometimes it's because you don't have enough OVD inside the EC, or sometimes it's because you're applying too much pressure with your gonial lens, or it's actually from your incision that you're pressing down too much. There's a few people that kind of like to say that you want to be kind of like a ninja when you're inside your incision, as in you're not applying any pressure at all on the walls. In this case, what you're seeing in these folds is they're actually kind of like these undulations. They're kind of parallel. If you're applying pressure from your incision, what's interesting is your folds will actually point towards your incision, and that gives you a really nice idea that that's actually the source of your folds. Unfortunately, my video here is actually just showing kind of when you're applying pressure from your gonial lens, leading to this parallel undulations. But again, it is kind of nice to know that when you're pushing down your incision, it will tell you, because you'll actually see that they're kind of radial and they're headed towards your incision. Now, an example here, again, TC's mentioned this, but in cases where you can't get away from heme on your surface, right? This is an eye where you see the conjunctiva is so hyperemic. This is partly from chronic drop use, and this patient has some pannus on your cornea. You'll never be able to go anterior enough with your incisions to actually avoid these, to avoid heme on the surface of your cornea. So here's an example of what we did here. And I just want to show you, as we're coming in, you see there's a lot of heme. We're not actually very posterior even. We're actually trying to go a bit more anterior to the limbus here, but you just can't avoid that heme. So when we're going in with our eye stent, and we have our gonial lens on top of it as well, I want you to see how this heme wants to creep up, but we're able to kind of keep it at bay. And one thing we're actually doing is we're avoiding lifting up on that gonial lens once we've actually applied it. And as you can see, we managed to get away with this and getting our eye stent in, despite the fact that there's just really not much you can do about this heme because of all that pannus and that hyperemic conjunctiva. And one last point that I want to make here is that, again, this has been mentioned, kind of this conscientious use of your viscoelastic. So the view here isn't great. I apologize for that. But the main point that I want to show you is you see there's heme in the AC. We've only placed our first left-sided eye stent, so we know we're going to have to do another one to the right of this. So what you see us doing here is we're actually applying viscoelastic to the right side of this left-sided eye stent, because we know that if we do it the other way around, now our heme's going to end up to the right, and as we're going in with our second eye stent, that's going to cause you a lot of problems. And the actual last point that I want to make here is how much OVD do you want to put in? So you definitely don't want this where you're applying your OVD, and what you see is as we're coming out, we see this kind of egress of viscoelastic. That's how you know that you've definitely put in too much. You've overinflated your AC, as you can see here as well. Why is that a problem? So when you're doing a lot of your trabecular bypass procedures and you want to access Schlemm's canal, if you hyperinflate your anterior chamber, you'll end up causing collapse, and it becomes very difficult to actually get in with your eye stents, let's say. So that's the last point I wanted to make. I think these are, we've covered quite a lot of concepts here that I do think will optimize your success. And hopefully for you guys, this has been valuable. So those are just a few of my 2 cents. We can move on to the next speaker here.
Thanks, Jeb. We'll let Allah load up his presentation, because I think that's where some of the meat is on the technique. And then that'll be followed by Valentina, who will speak a bit about some of the challenges. So with any questions in the meantime, Maria, about visualization or about, I see Andrea has a question about leaving air or viscoelastic in the AC after the procedure. Yeah, I think this is really important to prevent hyphemas. And we'll share the technique that we use. You may share it. I have a video I can show just to share how I do it. Sure. I think what you do in the eye afterwards is at the end of the procedure is going to be really important to prevent hypotony, but not also get a pressure spike. So I'll go ahead.
Ike, another question. If you discontinue the aspirin before the procedure?
Yes, I would. I would, or any blood thinners.
Yes, okay.
Okay, thank you everyone for having me. It's a great pleasure to be presenting in this webinar, and I'm really excited to give you all of my tips and knowledge about GAT. So this is why I call it what you got to know about GAT. So eventually, GAT stands for gonioscopy assisted transluminal trabeculotomy. And this is a technique that was described in the literature by Dr. Devinder Grover back in 2014. And the idea was that you do a goniotomy incision in the trabecular meshwork so that you can access Schlemm's canal. Then you use your suture to cannulate the Schlemm canal and go circumlinear throughout the 360 degrees. You retrieve your leading suture, and then you pull it out. When you pull both ends of the suture, you end up going.
Oh, sorry to interrupt you. I just noticed your screen is really it's like written in Chinese. I think. Do you have the English version?
Oh, really?
Yeah, on our view, it's like really blurry.
Yes.
Oh,
I don't know if it's internet connection or
connection.
Let me share it again. Let's see.
I thought it was in Spanish first, but then it was in Chinese. I'm like, wow.
Yeah.
So that's why Jed was understanding it.
Again.
We can answer a question here.
Yes. So some of the studies showed eye stent placement second or third in the eye provides superior outcomes. Yeah, for eye stent, no, Allah, still not working, Allah. I typically put at least 2 in. I think accessing the larger area of the canal is beneficial. And remember the studies by Morton Grant and Rosenquist showed that if you get beyond 1 clock hour is better than just 1 clock hour. So 2 or 3 are better clock hours. So by nature, putting more than 1 stent in would access more. Although you may have to then actually not optimize your videos for screen share. You know how you
not
want to share?
Yeah, sure. So
when you optimize your videos for screen share, you have smoother videos. The resolution of your images go down. That may be the problem. Or if you want, I can present it from my laptop, and you can.
So let me try to not optimize.
Try that,
if it doesn't work, then I've already shared it with you again. So.
Okay, this is better now. Yeah. So, don't show that.
Just one question. Just curious how to understand more about Uruguay. What is the glaucoma surgery that you perform the most there?
Here in Uruguay, I think that the most is the trabeculectomy.
Trabeculectomy. And do you have access to tubes?
Tubes?
Yeah.
Yes, of course. Yes. Ahmed tubes.
Ahmed?
Yes.
Okay, Ala, go ahead, buddy. That's better now. Your videos may be a little bit slow, but I think we can see the screen though.
Okay.
Perfect, Ala.
So basically, the technique then, when we pull both sutures, you end up having 360 degrees of trabeculotomy, ab interno style. Now, originally, the technique was described using a 6-0 proline suture. And then in 2016, they described using a 4-0 nylon suture, non-dyed, so it's non-colored, but then they mark the tip from the front with a marker pen so that they're able to track it while advancing the suture. And then the latest modification was to go with the 5-0 proline suture, as we all know, and the eye-track catheter that I'm going to be talking about, it was also described. So those are the main two articles I've been referring to. So the one on top is the one where they describe the technique and the preliminary results. And the one on the bottom was the author's 24-month follow-up results. There are a lot of articles in the literature talking about GAT performance in specific glaucoma entities or comparing it head-to-head with other things. But those are the main papers if you want to read more about GAT. So why we brought this topic specifically? So for me, it's exactly the same reason as in Uruguay and in other places in the world where access to MIGS could be limited. When I go back to Saudi Arabia, I might not have all the MIGS device options available, but I'm confident that when I learn something like GAT, I can perform it in my surgeries, like do it to my patients, and I would get very good results. It's a very effective procedure. It's accessible, and it's one of the cheapest MIGS options that you can go for. So any patient who has any form of open angle glaucoma, either primary or secondary glaucoma, in a mild or moderate disease spectrum, and is cooperative enough to follow restricted, very tough postoperative physical activity limitations, mainly not bending, no Valsalva, no exercises, are a candidate. A very big highlight I would give to not being on anticoagulation. The last thing you want is to have them on warfarin and you do a GAT procedure and then you end up with total hyphema and you don't know how what to do with it. And we've seen that. I remember seeing a case that went really south. So those are some of the contraindications. If you have a patient who have abnormal anatomy overall, you're unable to find Schlemm's canal, they have unstable intraocular lens, bleeding issues, extensive peripheral synechia, you cannot stop their anticoagulant, you should not be doing GAT for them. Some other stuff are relative contraindications based on some experiences. So if you're having difficulty viewing the angle, unclear corneal media, some would say that doing preoperative, if someone has preoperative visual field defect of more than -15 decibel, that you should not do. This is as per the Dr. Grover's group assessment was. They found that GAT have underperformed in patients who've had advanced glaucoma disease. But I'm sure there are other doctors who've had experiences in advanced glaucoma as well, and other literature. Now, depending on your choices, you can go for GAT being the cheapest surgery ever to be done for, as a mixed procedure, or you can make it a little bit fancier. So you can go with a proline suture, which is all what you need to create the trabeculotomy effect. And this is really cheap. And if you want to go for a more sophisticated procedure, you can go with a eye-track catheter, which is a fiber optic catheter connected with a viscoelastic injector and with an illuminator device. And basically two advantages you get with this. You're able to track your progress all over because the blinking laser light will guide you where, and you're able to tell at which quadrant of the Schlemm canal you're in. This is a disadvantage with the proline, where sometimes when you're stuck, you're unable to determine what is your progress, and you have to go with your guts and feeling. And the second option is, if you go with the eye track, you can actually perform ab-internal canaloplasty, or ABIC, ABIC, along with the GAT. So you do both viscodilation of the collector channels along with the trabeculotomy effect. Now, the other basic instruments that you basically need a blade to create the goniotomy, the initial goniotomy. So in this slide, I've placed our own preferences is to use an MVR blade. You can go with a 20 or 23 gauge MVR blade. You need something that's long and flat enough to create the goniotomy. You can use any set of micro forceps. Personally, I find the micro tires are the best to grasp the suture without like collapsing the suture, especially if you're using the catheter in your GAT procedure. Some forceps can collapse the catheter and kink it. The micro tire is excellent. Now, one tip I would give to all of you, the micro tires and the MST set, there are two types. There are ones which are horizontal and vertical. The bend is different. Ones that have the bend being vertical and the other has horizontal. I usually go with the horizontal because I feel that the vertical bend can actually depress on the posterior lip of the wound, and then you lose viscoelastic while like moving or swiping your forceps. And then you need the low temperature cautery or a Bovie cautery, and this what we'll need to create the mushroom bulb if you're doing the proline GAT. Obviously, you don't need this if you're doing the catheter method. Now, other alternatives, if you want to go and like go even low with the budget, so you can use a 25 gauge needle instead of an MVR blade, and this should be cheaper, and you can create the goniotomy in the same effect. Now, I could argue that a grease happer could be on the long run more expensive than an MST, because in an MST forceps, you invest on a microsurgical set and you keep for long, but then not all people could afford getting MST at the beginning. However, grease happer forceps are available at your retina colleagues. So if you can borrow it from them, then you're getting them for free. So this is another way to go around it. So here are some operative tips, then I'm going to show some videos. And so the number one thing is when you position the patient, it is better to always put the patient in reverse Trendelenburg position. So this helps keep the blood flow below the feet, and you prevent any blood reflux to the head section, and therefore you decrease the risk of having intraoperative bleeding or congested vessels as well. But you have to also make the position comfortable for you as a surgeon to work. You don't want to be really sitting high up, and then the procedure becomes very difficult. As Tiziana have mentioned perfectly, you want your wounds to be directional. Obviously, your usual paracentesis incision will not work for a GAT procedure. If you put your suture this way, it's going to be transecting the pupil. And imagine you want to push it this way or this way. It's going to be in the way and it's going to be kinking. And it might redirect the suture into angles that you don't want to go. On the other hand, you want to go in a directional tangential route, aiming to the angle. This is how I used to do my incisions at the beginning. When I joined Ike's fellowship, one good tip I learned from him is to go even more tangential, more closer to the nasal angle. And this is how he does his incision. And I started to adapt this. I think one benefit for it, if I can share with you as well, is that when I previously used to do GAT, you usually have a long thread of suture laying on the eye at the beginning of the procedure. And meanwhile, while you're moving your forceps, sometimes your grip gets caught into the suture. So imagine you're pushing your suture in and then your arm is pulling it out. So I think when you have it closer over here, it's like the suture is away from you. So there's no risk of it getting caught easily. Now, the question is also...
Just one thing on that one. Remember, of course, in this case that you're showing here, you're planning on doing your goniotomy, your incision is always based on where the goniotomy is, right? So you're planning to make the goniotomy here, right?
Yes. So this is the next point that I want to speak about.
So therefore you're good. But if you're going to make the goniotomy, let's say here, and this was, let's say, a right eye, because you want to start infranasally, then of course you have to make this incision. So base your incision on the goniotomy. That's the bottom line.
Yes. Yeah. So I guess the second point is, should you go superior or inferior? So this is it depends on different variables. So number one is surgeon comfort. Some surgeons are comfortable working with backhand or forehand, and therefore they can go in either direction. Others are not very comfortable, and they want to go always in the forehand position. So I know some surgeons who would go like inferior GAT in one eye and superior in the other because it suits their right hand. Now, for me, I always go for aim for superior, and I think Ike have alluded to or suggested that he does superior hemigat as well. There are a couple of reasons which I think are important. So number one is, as he said, like if you do an inferior GAT, you end up having collection of hyphema at the site where you've had the trabeculotomy done. So when you see the patient in the early postoperative period, you're gonna have pressure spikes because obviously your goniotomy is blocked with the heme clot. But what I think as a surgeon as well, and especially if you're gonna be doing 360 degrees GAT, why you should go superiorly is that once your suture passes the 180 degrees, this is when you start to feel some resistance while pushing the suture. Imagine if you go to 270 and then your suture is like completely stuck. So what you're gonna do in this case, you need to do what we call a like an incisional cut down to retrieve the suture from where it was stuck. If the suture got stuck inferiorly, then you can just shift superiorly on top of the patient head, and you can just, with your gonio view, and you can just retrieve the suture. Now imagine if you went and started inferiorly and your suture got stuck superiorly. It is difficult to go beside the patient's shoulder and body and rotate your scope and everything and try to retrieve the suture superior. So ergonomically, it is much easier to anticipate the suture to be stuck on the inferior quadrant. I'm happy if Dr. Ahmed wants to also comment on that.
Yeah, I think that's a reasonable point. I mean, again, as you probably know, we are primarily moved away from 360 and we're basically doing 180, so it doesn't become an issue. But yeah, once you're at the last, the second 180 and you're passing 360, that usually is where you have more resistance. And it makes sense. If you have to do a cut down, then you'd rather kind of cut down in the inferior quadrant than superior quadrant where you've already started. So, but the bigger reason is, I think, is just if you're going to do a GAT, if you do it only inferiorly and you get bleeding, then you basically have blood blocking your ostomy, right? Your otomy. So
exactly. I totally agree. And it's not of an issue, as Ike said, that if you're doing a 180, it doesn't matter which direction you go, but then you should consider what he said as to start with the infranasal goniotomy instead of being straight nasal. And this is because this is the area where you have the abundance and collect of the aqueous veins over there. So, and we always advocate for targeted MIGS procedure rather than just doing MIGS procedure randomly and everywhere. So the other tip is when you cauterize the bulb. So you can end up with having a very small bulb, you can have a very large mushroom bulb, or you can have a tilted bulb. And this happens if you not align the tip of the suture along with the tip of the cautery in the same plane. So I would say to aim for a moderate size mushroom bulb. A very large bulb may work out with you in 180 GAT, but you might get stuck occasionally and you can't advance the suture furthermore. If you go with a very small bulb, sometimes it's fine enough that you can actually pierce into a false passage and go into the suprachoroidal space. Or I've seen it in a couple of cases where for some reason with the angulation, the suture is able to pierce through TM and it finds its way outside of the, into the anterior chamber, and it curls and it gets stuck into the iris root. So I would advocate for going for a medium-sized bulb, not too big, not too small. we've already went into the topic of superior inferior. Now, should you go for, should you go for a superior GAT, a 360 GAT or 180 GAT? So this is a topic of debate, but then we do have reasons to think that we've looked into some cases that we've done, and we've noticed that there might have been similar efficacy between both techniques. But what noticeably all of our group have noticed is that the rate of postoperative hyphema is much significantly less with the 180 degrees GAT. And I can tell you, as someone who I've been trained last year, I've done in Miguel, and I've done a lot of 360 GATs, and doing now more 180 GATs with Ike. When I'm seeing the patient postoperatively, I haven't got those patients who've had massive hyphema all around with 180. And it's quite impressive to have such a finding and with the same efficacy. Now, those are signs, important signs to look for and to suspect when you think that the suture might be deriving into the suprachoroidal space. If you're having difficulty in doing the goniotomy and the insertion of the suture, if it's not going in, if you're advancing the suture and instead of expecting some increasing tension or increasing resistance, you're finding that the suture is going really loose. So you have to suspect that it might be going into suprachoroidal space. If the patient is in extreme pain, now sometimes make sure that the patient can get in pain when you touch their iris with the forceps, but if they're jumping out of the bed, or if they're really gasping, they're really uncomfortable, then this is a very, very alarming sign that this is going into the suprachoroidal space. If you're having heme while advancing, and when you're removing the suture in a hemi-GAT technique, and it's backtracking instead of doing an actual trabeculotomy, it means that it actually went posteriorly into a suprachoroidal space. So it's not actually pulling on the trabecular meshwork. Things to look for postoperatively: you should expect hyphema to be one of your concerns in the postoperative period. So you could always fill the eye at the end of the case with 10% OVD. Cohesive is preferable. Keep the patient on head elevation, abstinence from strenuous physical activities. You have to have them on high frequency steroids because they likely have more inflammation, which is expected because of the nature of the procedure. And IUP spikes are a common thing to face with GAT because either of the amount of OVD that you leave in the eye, hyphema clot formation at the trabecular meshwork cleft, or steroid response eventually with time. So I'm going to show a video. This is from a 360 GAT procedure. Some of the techniques that you're going to see here, it's before I've started training with Ike, so obviously they're different. You see my incision is directional toward the nasal angle, and I'm injecting over here lidocaine, then a mixture of Myocol. I'm filling the eye with a viscoelastic, and I make sure that the eye is really deep. So I don't want any chance for bleeding to happen. I'm doing the incision. Now, obviously, because this is not a phaco case, so I can use the same MVR blade instead of opening a new like 2.2 millimeter incision. I've done cautery to create the bulb. Okay, and then I'm going to introduce the suture in. I'm going to speed up this a little bit. This is topical lidocaine jelly. This is one option you can do for review. So to answer Maria's question, so with the MVR blade, I go into the trabecular meshwork and I transect, I do a central line, and then what I'm going to do, so I pierce through the TM, not on top, not below, and then I dimple, and you can see with the dimpling, did everyone see how there is a space that got created? Now, oops, sorry. Now, a very important thing to mention as well is that, and I learned it the hard way, sometimes if you go on top of the TM, you could slice an incision, and when you depress, you think that you've created a plane, but you've actually created like a false entry area. Like you're gonna be putting in the suture, and then it goes into like Schwalbe's line, and you don't know about it until you face obstruction early on in the first 90 degrees. So be sure to have your incision exactly at the center of the TM. Otherwise, you could be misled and thinking that you're in Schlemm's canal, but you're not. So I'm gonna continue the video over here. I've introduced the suture in, and you can see how it goes smoothly and nicely into the Schlemm canal. And I start advancing it, and I'm pushing very slow. If you're pushing at this rate in a small steps, you can take up to 20 steps to reach into the 180-degree quadrant, and you need 40 small pushes to reach a full 360. In the end, it depends on how wide and how big is your swipes. So it differs from one person to the other. But this is roughly a guideline that we will use. So now I've retrieved the suture. I pick the leading suture end with my micro tire, and I pull it out. Now I go to primary position and see how we pull the suture out. So there are two techniques. Either you keep the leading suture centrally stable and you pull the trailing one from the outside. Another way to describe it as well is, I'm gonna replay it again. Another way, and I find it being easier, you can pull this suture from the beginning outside of the wound. So you're like gatting the first half, and then when you remove this part, it gats the other. So this is a very simple way. And this is a very cool thing I want to show you. This is the episcleral venous fluid wave. So I'm going to hydrate the wound, and I want you to notice the episcleral vessels. So I'm going to over pump the pressure, and notice how the blanching happens over here. Did you all see that? And when I deflate the eye, the vessels reblanch again. So this is a very cool and neat trick to see how your GAT is working well. We don't routinely do it nowadays in every case, but I remember doing it in every single case. So this is 180 GAT from my excellent colleague Valentina. And you can see over here, she's doing her incision. She's already created the tangential directional incision over here. And she's gonna aim for a supranasal goniotomy. She's cauterized her suture.
This is 5-0 prolonged, not 6-0, just to correct.
Oh, yeah. Okay. You see, she's not going exactly nasal. She's going a little bit toward the supranasal. She's dimpling the wound, and then she's going to introduce the suture.
Yeah, like I said, if you're going to go offset, I would suggest to go infranasal. I don't know if there's an advantage going supranasal.
Oh, sorry, infranasal. Sorry.
Infranasal, yeah.
Yeah, infranasal, sorry. Yeah. So she introduced the suture, and now while she's pushing the suture in, she's counting in her head until she reaches 10 or 12 pushes, probably. She's pushing harder than what we do. So she's already reached that level. So what she does is she grabs the suture over here, and we do a technique, what we call walking the dog. It's like when you pull your dog out in the park. So you just pull the suture toward the main wound, and the suture follows you. And by this way, she does the 180-degree GAT. So I guess this is the end of my presentation. One last thing to comment on is, should you do GAT before or after and phacoemulsification? And this depends on your preference. I know people who advocate for doing mixed procedures overall after cataract surgery. They're concerned about hitting the lens capsule while doing the mixed procedure before. They want like more dilated or like more open angle approach by removing the cataract. From my personal experience, I don't think that this is necessarily correct. I've never had an issue with dilating the lens capsule while doing mix before. I do feel that the chamber is more stable when you have viscoelastic and the lens in and you do a mixed procedure before. as compared with after, when you put an IOL and the viscoelastic has very loose, less resistance to come out of the eye, you get more deflation. But this is a personal preference, I would say. So thank you.
If you want to just release your screen share there, and then maybe we can take questions, Maria.
Yes, I have a question. If you are going to do a combined surgery, do you delay the patient previously, or do you use myotics, or you just do the surgery and after that you delay the patient?
There's no problem, dilation or constriction. There's no need to do either one. With viscoelastic, the angle opens up beautifully and you see everything you need to see. So there's no concern about dilating. There's no need to constrict.
Perfect.
Yeah.
And to ask also, because you didn't mention that, you have said that when you end the surgery, you used to leave viscoelastic, no? Intracameral viscoelastic.
Yes.
Which kind? Do you use dispersive or cohesive? I know that you use cohesive to do the surgery, but leaving in the anterior chamber,
So here's what we do now. This procedure, by the way, I'm just showing you. This is actually an Omni procedure. It's like a GAT, but the suture is actually in a specially designed single-handed instrument. So don't worry about this. Let me look at the end of the case. Here's what I think the best way to do this is to, first of all, use Helon. First of all, I personally think it's good to evacuate the viscoelastic from the eye if you can. And then, or at least most of it, and then put some air in, because if you put the air in, you can see how much of viscoelastic is left. Otherwise, it's hard to tell how much viscoelastic is in the eye versus how much aqueous is in the eye. And then after the air is in, I like to leave about a third. I don't think 10% is enough personally. I think a third, like you see here, to fill the AC up is reasonable. And by having air in, it actually helps you to see how much viscoelastic is left in, because viscoelastic here, you see, has occupied, this area of the AC, and the rest of it is but the air. And so basically it has, a good way to measure it. But I think you should put viscoelastic in. I think that 1/3 is good. And I think it depends what you use. I'm using Helon typically, and Helon I think is a good agent to use. So of course, you don't have to put air in. You can just put the viscoelastic in or leave it in at the end of the case and just burp out the viscoelastic. Many ways to do it, but that's definitely a subjective part of you to decide how much you put in. It's hard to control how much you're putting in and know how much you put in, unless you, I think, put in the air.
And if you have the other day, how many hours after the procedure do you control the IOP? Just to know if you have a spike, for example.
Next day, typically. On the other hand, if you're worried about somebody, then yes, you can see them back after 3-4 hours if you're concerned. But I would rather have a little bit of a higher pressure and manage this than have low pressure and have hyphemas. Of course, if the nerve is very delicate and very damaged, then it's good to see the patient back after maybe 4 hours. 1 hour is too soon. And if they are really high, you could tap off some of the viscoelastic a little bit.
Okay. Is there any question, Rosario, to answer, or Miguel?
Everything's fine.
Okay.
We don't use Diamox. We don't use pilocarpine afterwards routinely. Unless we're worried about the angle is getting synechia in the first week after surgery, we don't typically use pilocarpine. Which kind of patients benefit GAT the most? I think patients who are combining with cataract surgery, who are on 2 or 3 medications, who don't need to have pressures of 10 or 12. That's a lot of patients. Or somebody who's not going to cataract surgery, but the pressures are too high and your target is 15 to 16. That's reasonable. Or the patient cannot tolerate medications. They are intolerant, they're not taking them. And again, the target you're looking at is 15 to 16. Remember, you can always go to a trabeculectomy after a GAT. There are some downsides. Sometimes during the trabeculectomy, you can get hyphema from the opening you do. But for the most part, it's fairly safe to do a trab after you do a GAT or suture trabeculotomy.
And as you say this, in the other way, if you have a patient that has a failure trabeculectomy and you don't want to do a second procedure with the conjunctiva, can you do a procedure like Like
you can do it. You may have trouble passing the suture in the area where the trabeculectomy was done, though. But the bigger problem is the reason why you did trabeculectomy, I'm going to guess, is because the patient needs a low pressure.
no, but because here, for example, in my city, many patients that don't have, that can afford the medication or perhaps don't have it, and they don't tolerate. We don't think about another procedure. Perhaps with mid-teens it's okay, and we have already done a trabeculectomy because we don't think about another procedure, or perhaps.
Yeah, I think that you can do it. I just think the success rate will not be as high, but there are cases where you can get some good lowering of pressure. But again, it's not going to be very low. It'll be perhaps, again, 15, 16, whatever number that is. And if that's good for your patient, great. My preference is typically if they have a trabeculectomy to needle them. But I'm assuming that you've already tried or you can't do it. But most of my experience is not doing these procedures in patients with failed trabs. Those patients are bad, they're advanced, they need low pressures, and GAD isn't enough.
And how long does the procedure remains or survives?
Well, I mean, we don't have good data on long-term data, and any data we have is retrospective and is highly selected and is very biased because of attrition and lack of follow-up. So it's really hard to really give you a good answer, unfortunately. And that's the same problem we had with trabeculectomy. We didn't have good long-term data until we had really the primary versus tube study or TVT study. We didn't really have good data on that. So, but I would say in generally speaking though, I mean, the Kaplan-Meier curve, every year it goes down a bit, you know? But I do think that if the patient does well in the first 3 months, that many patients will continue to do well for a few years. That's the best I can tell you.
Somebody asked about SLT after GAT.
Well, I think you can try it. I don't think it really will. If you do it in the area where the GAT was done, then you know I don't think it'll give you much benefit because either the cleft is already open still, or it's closed because you've got scar tissue there, and doing laser over that won't help you. But if you do SLT in another area, then sure, I think it can be done quite well. Congenital glaucoma, people are asking, yes, for sure, absolutely. But in congenital glaucoma, the anatomy can be quite anomalous. And so, you know, I think that it's advisable to do the eye track, which is a more robust instrument to use. And you can see exactly where it is. It's easier to follow through. And later on, if you wanted to show a video, but the eye track to perform it is, I think, a better option than using a suture. A suture is harder to pass through, but it's not impossible. Definitely can.
Thank you.
So,
to start performing these surgeries, would you recommend doing it in phakic or pseudophakic or just combined surgery to start performing these surgeries?
To start, I would do pseudophakic or combined because doing it in a phakic eye, there's more risk involved. And so I think that I would say that this is something that I would be careful with in a phakic patient early on, although we have.
Just because you're training or because it's better for the pseudophakic eye?
I think in general it's better for pseudophakic eye. I think in general because the angle is more open and I think the scleral spur position is more posterior, which I think can benefit. But that's one reason why I think it's more successful. And also with phakic eyes, there's a risk of hitting the lens, of course, in cataract formation. But believe me, I've done them in phakic eyes too. I would do it, but it just, I think the result will be better. And for someone starting at least, I think it'll be less risky.
It's very risky having microphema.
No, microphema is not terribly risky, but it does, you know, it can cause clot formation and pressure spikes.
I mean, a couple of months post-op.
Yeah, I mean, it's very uncommon to see that, but yeah, sometimes you get reflux bleeding well after the eye's healed, maybe with straining or Valsalva or recumbent position. It has happened. Yes, it has happened. This is one of the long-term complications of an otomy technique like this. But it's rare, and generally speaking, it's not something that's clinically significant. We've done some where we had to laser the canal or close the canal, but it's very, very rare for us to have to manage that. But it is potentially one of the late complications is a recurrent hyphema. Yes.
And if you have a very, not so huge, but a hyphema that is worrying you, how long do you wait to go back to the OR and wash it out?
It partly is dependent on the pressure. If the pressure is good, I think you can wait, assuming the hyphema is not very large. So if the hyphema, if it's an 8-ball hyphema, of course, then you're going to be going in, right? But if it's 1/3 or less, hyphema and the pressure is controlled, I think you can wait for this, certainly. I'm not too worried about blood staining in those cases. So I think it depends on the pressure, but the pressure is high, then you really have to go in pretty soon. Even if you have a smaller hyphema, if the pressure is 30 or 40, you can't wait more than a week for that. You should go in, for example, in that case.
Okay. Well, thank you.
What usually you do if you have a complication with gut, like false passage, false route?
Well, usually we try to go back the other way. If we start clockwise and you feel that the suture has gone into the suprachoroidal space or you cannot pass it, then go the other way around. And just be prepared. You may not be able to do a 360, which I don't think you need to anyways. I guess if you go both ways and you cannot go anywhere, then I would make a goniotomy elsewhere. Maybe I move my chair and sit superiorly, and I make a goniotomy inferiorly, for example, and pass the suture that way. But you should be able to get at least some, 90 degrees of your suture passage. And if that didn't work, then take your MVR blade and use the MVR blade or your 20 gauge needle and do your cut along the TM like you do a goniotomy. I mean, that's obviously one option. There's a risk of injuring the back wall, the outer wall with the MVR blade or the needle when you do this. But if you do it properly, you can still cut the canal open, slice it open with a blade. Or you can do like the bang technique that one of my former fellows talked about, which is using a bent 27 or 25 gauge needle, like a cystotome, and turn on its side, put the cystotome tip inside the TM, and then sweep along the canal circumference.
Like doing a hook, similar.
It's exactly doing a hook, yes. Correct.
Thank you.
So I don't know how much time we have, Maria, but you have time to show one more video here?
Yes, of course.
Okay. Valentina's going to share some challenging cases.
Hola a todos. Sí, quiero hacer un resumen en realidad de los problemas que tuve yo y quizás les sirvan a ustedes. Tiziana y Ala ya dijeron varios, pero solamente lo voy a repetir para que les quede claro. Empezamos con la incisión corneal. Como dijo Tizi y Ala, quieren que sea direccional. En realidad me pasó mucho que lo hice con dirección al iris, por lo tanto costaba mucho agarrarlo con el microforceps. Como ven aquí, fue muy fácil agarrarlo. Aquí hay otro video. En vez de usar el cuchillete de diamante, usamos una aguja de 27G y nuevamente direccional, apuntando hacia la malla trabecular. Es muy fácil agarrar el prolene con los microforceps. Así que eso es un buen tip. Después, como dijo Alá también, no hay que hacerlo tan grande, por si no va a costar que entre por el canal, ni tampoco muy chico, porque uno puede causar un pasaje falso al espacio supracoroideo. Así que ahí les puse una foto para que vean después, ese es como sería el porte perfecto. Después, cuando estamos haciendo la agonotomía nasal, como ven aquí, pueden ver claramente lo blanco que se ve el canal, y como ven acá también no sangró, por lo tanto fue muy fácil poner el prolene. Pero en este caso hay flujo de sangre, por lo tanto eso me impide la visión, y aquí es cuando decimos que pueden usar el viscoelástico para empujar la sangre hacia un lado, y ahí nuevamente poder ponerlo sin problema. Y también mostré otro video, en realidad este es con el Omni, y por aquí también, como hay que hacerlo 360 grados, empujamos el viscoelástico y empujamos la sangre para poder llegar y hacerlo en el otro lado. Y eso sirve muchísimo. No hay que sacar la sangre, no hay que volver a sacar toda la cámara anterior, sino que simplemente se puede empujar. Y aquí nuevamente uno, ya que está dentro, da lo mismo que sangre, porque en realidad esta parte es, uno siente cuando está pasando. Así que no importa si aquí nuestra vista se oscurece con la sangre. Ya, y en el otro aquí, yo uso el gancho de Kuglen, y por favor hagan las incisiones muy grandes. Como ven acá, me la peleo con esta incisión. Así que hágalo un poco más grande de 1 milímetro. Y no puedo, pero lo que quiero hacer es entrar con el gancho de Kuglen y lo logro poner en el prolene que está conectado a la trabeculectomía, porque no quiero que se dé una vuelta 360. Entonces lo engancho y sigo tirando con el otro prolene y ahí solamente hago una trabeculotomía de 180 grados. No quiero que se pase 360, entonces esto es una manera buena para poder prevenir eso. Y ahora lo que muchos preguntaron es cuando terminamos de hacer esto, ¿cómo sacamos la sangre? Y aquí, como ven, la saqué simplemente tirando solución salina y sacando todo el viscoelástico. Lo que es muy importante hacer es que en realidad cierren las incisiones lo antes posible. Presuricen el ojo, cerrando todas las incisiones, o si no va a sangrar muchísimo. Entonces aquí, por ejemplo, sacamos todo el viscoelástico y presurizamos el ojo. No dejé viscoelástico acá en realidad, pero como dice Ike, usualmente sí ponemos gimo. Pero tuve suerte, no me sangró mucho. Veamos si viene el siguiente. Ok, aquí, en este caso estoy tratando de hacer aspiración seca y lo estoy sacando, me está yendo muy bien. Empiezo a irrigar. De nuevo, todo bien aquí. Pero miren aquí lo que me pasó es que traté de sacar un poco más de la sangre que quedaba y la presión del ojo bajó muchísimo. Y como ven acá empieza a sangrar en todo el área de donde tenía la trabeculotomía. Por lo tanto, muy importante dejar la cámara anterior presurizada como dije antes. Aquí de nuevo traté de sacar todo y cerrar las incisiones para dejar la presión alta. Usualmente no nos molesta dejar el ojo como en una presión de 30, la verdad. Bueno, y el último, este es ya sea después de la cirugía de catarata. Déjenme aquí. Acá. Entonces aquí esto fue después de la cirugía de catarata, lo logramos hacer, aquí estamos usando la FACO, la irrigación de aspiración, y como ven, mientras saqué la aspiración, empecé a echar solución salina con mi paracentesis, por lo tanto, siempre quieren tener una cámara anterior bien formada, ahí cierran las incisiones, y en este caso sí ponemos un poco. Tenemos otro doctor que él usa un poquito de dispersivo, como estamos poniendo acá, siempre dice como 10-15% y después ponemos un poquito de cohesivo, 10-15%. Y eso así mantenemos la presión alta. Y eso es.
Valentina,
dime.
¿Es frecuente tener iridodiálisis o ciclodiálisis cuando haces la primera incisión y bajás con el cuchillete o no?
No debiese, porque no debiese de estar tocando el iris, estás tocando la malla trabecular, por lo tanto, claro, no, solamente baja. Vas a ver que cuando hagas la gonotomía, vas a tener un poquito de como de un flap que vas a poder bajar, no estarías tocando el iris.
Pero al principio tampoco tenés ese riesgo, cuando empezás, digo, no es común.
No es común, y si te da miedo que el iris está muy cerca, simplemente pon más viscoelástico para que se baje.
¿Y desprendimiento de la DCMED, por ejemplo, si haces muy superior el corte, han tenido?
La verdad que yo no, pero Ala me estaba diciendo, Ala, you were saying that you can get a decimal detachment with these. I haven't had experience with.
So it is possible that you get decimal detachment during GAT, actually with any mixed procedure, and it depends on your forceps movement. If you're having your micro tires or your instrument, your mixed instrument close to the cornea endothelium and you're not respecting the vertical, horizontal axis, and you're bumping into the cornea, then yes, you could get a nasal decimal detachment. This is it can happen with GAT, especially when trying to sweep the suture in.
Yes.
So I think we need to differentiate just trauma from the forceps, which can happen, right? No question, versus when you actually do the trabeculotomy with pulling the suture, whether that could cause you to pull Descemet's off, right? I think they're two different questions. The first one, yes, I think most people will get some Decime's trauma near the incision. I don't think it's significant. I'm sure if you measure the cell count there, it's lower in that area, but I think it's minor. But yes, paying attention to your forceps is important. I think doing it with pulling with the suture is very, very unlikely. You know, the attachments at Schwabi's are pretty strong, and the TM is what gives first. So I think that's less likely. Same thing for cyclodialysis cleft. I think that would be or neurodialysis would be very unlikely, unless you have synechiae formation and you got iris into the TM. That may be a different story. So that's not really an issue. We did get some Decime detachment when we inject viscoelastic, however, because then we're injecting viscoelastic in a small space, and that can push up into the cornea. But with the suture, we're not injecting viscoelastic, so it's not usually a problem. So maybe let's take some questions. Let's take some more questions, Maria, because I want to make sure that we can answer anyone's question.
About the post-op, there are questions about the post-op.
Yes.
How do you manage it?
So post-op, some people are asking on YouTube, they're saying, do you stop the glaucoma medications? Yes, we stop the glaucoma medications. We don't want to get hypotony. But keep in mind that sometimes the pressure goes up in the first early post-operative period. It can happen because of blood, inflammation, and maybe steroid response after a few weeks. And in that situation, we would have to then restart it. But once the steroids are washed out, then think about holding back those medications, because that may be all they require. So something to be aware of. I have to say with GAT, I still feel a little bit worried about hyphemas. And so we still tell patients to take it easy for, you know, the first 3-4 weeks, because they could be at risk for hyphema. After that, they go normal, whatever they normally do. It's one of the reasons why I like the stent, because stenting, you really don't have to worry about hyphemas. Efficacy-wise, if you put them in properly, they can be similar to a GAT, I think. But then there's cost.
How many weeks the patient cannot do exercise? Then you said 3 weeks.
I say 3 weeks to be safe, 3-4 weeks.
And what about having the patient the head up for 2 weeks? When sleeping, for example, do you use?
Unless they have hyphema, then otherwise I wouldn't worry.
Oh, okay.
If they don't have an hyphema, then you're okay.
And before doing the surgery, would you stop medication or only after the surgery? For example, prostaglandins or? I don't think
you need to stop them, but it's a good idea that can prevent hypotony early on, right? Because one reason you may get low pressure in the first day is the drugs are still in the eye, they're not washed out, and then you get low pressure and they get bleeding. So I think it's nice to do that. Practically speaking, though, you know, to tell patients to wash out of medications and they're worried about their pressure and everything else, we don't often do it, practically speaking. But I think it is a generally a nice concept as well. Of course, if the meds are causing irritation to the conjunctiva, then stop it, because you don't want to have bleeding and conjunctival issues with it. And if the conjunctiva is not happy, the cornea is probably not happy either, and your view won't be good either. So I think stop medications when they're causing toxicity to the eye, though, either way.
And I don't know if you have any other question here in the chat to answer. If you have.
As far as the goniotomy, honestly, if you can't do a goniotomy with your MVR blade, I think there's a problem. Like, that's not hard to do. Like, really, I mean, go in there, look at the trabecular meshwork, put the needle in, right? Even push more than you think you need to, that's fine. You may damage the outer wall, but no big deal in that area. And then swipe left and right. And make it big enough. Don't make a small little opening. Make it big enough. Like, make it like 1 clock hour, you know? And then, as Allah showed, pull back a bit and use the tip of your blade to push on the posterior lip. The posterior lip. Okay, this can cause the goniotomy to fish mouth open. Okay, some people actually put a 25 gauge or 20 gauge needle on the viscoelastic and use that to do the goniotomy. And then they do the goniotomy, and then they inject viscoelastic while they're in the goniotomy to clear blood away, because that's the bigger problem. The bigger problem is bleeding that occurs with the goniotomy. So never allow the eye to fill with blood. Always pressurize the eye. If you get bleeding, then inject viscoelastic. And that's one of the biggest reasons to do GAT before phaco when you do combined procedure. If you wait to do GAT after phaco, you will get more bleeding because the eye has been pressurized and collapsed and back and forth during surgery. and you get less bleeding when you do the GAT before phaco than do it after you put the lens in.
Mm-hmm.
Biggest reason why people who are doing GAT for the early experience, they get very frustrated by bleeding in the anterior chamber. So take 2 viscoelastics, use them if you need to, overpressurize the eye when you do goniotomy. After you do the goniotomy, put more viscoelastic in. It's nice to have the Prolene suture in the AC before the goniotomy. One little tip I think that they may have mentioned is before you tilt the scope, put the suture in the eye. Okay? If you tilt the scope, then you got to put the suture in the incision, in the little incision. It's hard to get because the eye's tilted away from you. So make your incisions, put OVD in the eye, put the suture in the eye, coagulate the suture, right? Go high temperature and come close, or low temperature and go close to the tip and get a nice round head, right? I know it's hard to describe how big and how small to make it. I think that, yes, it can get too big sometimes, but just get enough that you get the formation of that round head. Put it in the incision and put more than you need to. Otherwise, it may pull out when you tilt the scope, right? So put extra in the AC. You can always pull it back, put extra in there, and then tilt the scope, and then use a MVR blade to go and make your goniotomy, and then put more viscoelastic in, and then take your microforcep and grab the suture and pass it along. And if you make your incision directly across from your incision, it's easy. If you put it infranasal like I like to do, it's harder, because remember, if it's, for example, a right eye, now I have to hold my instrument like this, like at an angle to grab the suture and go this way, rather than go right across. So for example, I'm right-handed, so doing an infranasal goniotomy for a left eye, easy. I just have to hold like this and go across, and I can go in, right? But if for a right eye, I have to basically grab my forceps like an overhand grip like this, in order for me to grab the suture and then basically go in a counterclockwise fashion. I don't know if you appreciate that. My recommendation for you first starting is make your goniotomy right across from your incision. Don't worry about infranasal like I'm trying to recommend. Do that for later. For now, just go right across. Make it at 3 o'clock, for example. If you're working on the right eye, make your temporal incision 9 o'clock and go right across and make a goniotomy and do it there. That's fine. It's a good way to start.
Okay, very good tips. I think Andrea is asking something. How long does the eye pressure remain low with this procedure? It's what Rosario has asked. No?
Yeah, I mean, the data we have on this, we really have poor quality data. We have retrospective data, and it's not the best quality, unfortunately. So you can look up the papers that Allah showed. I mean, we have 1-year results, some 2-3-year results, but they're very, very selected, right? Their follow-up is quite variable. But like I said before, I would say that probably in my again, without getting into specific stats, about maybe 10-20% will not work. They don't do much. Maybe that's too high, but they don't work. The ones that work, though, they'll work for a few years, I think. I don't think that they suddenly stop working at 1 or 2 years. But every year you'll lose a bit as you follow the follow-ups.
And I have one more question, and is if you have a mild glaucoma, would you do this procedure, for example, not 180 but 90 degrees, or prefer not to perform this surgery?
Absolutely, for sure. I think it's a great case to do it. And I think 90 versus 180, we don't know. Maybe 90 is just as good. I don't know. I mean, we didn't talk about KDB, but hook dual blade is pretty well 90 degrees. And the results, in fact, maybe not that different.
Recently, it was published a paper comparing GAT with Cahook, and the results are the same, even better with the Cahook one.
Yeah, I mean, again, this is the challenge with some of these studies. They have lots of biases and things, but I don't want to say it's better, but I would say that I think they're probably similar, yes. So, you know what, 90 degrees may be fine for many cases too.
Rosario, do you have any other question? You are silenced.
No, there is a question here that you have done a SLT after GAT.
Yes.
Yeah, I answered the question before. I just think that if you ask the question, sorry, if you do the SLT in the area where the goniotomy was done, I don't think it's going to be much benefit because you either have an opening already or you have a scarring in that area.
Yes.
But you can do it elsewhere where you haven't done the goniotomy. It's another reason not to do 360 either.
Yes.
In my opinion, I would always try SLT first. Why not do it before GAT? I would not do GAT first, unless maybe you're doing combined cataract and you're already going to do surgery already, so you're not going to do SLT now, perhaps then.
And do you have any difficulties if you perform SLT first?
No.
Because of scarring or?
I mean, maybe with a heavy duty ALT treatment, it might cause some difficulty, but are you doing SLT or ALT more?
No, SLT.
SLT, I think no problem. ALT, again, I presume you're going to use low energy nowadays, so it shouldn't be an issue.
Mm-hmm. Okay.
Ike,
no, not aprendí.
When you have a patient with cataract and glaucoma, it's always mixed or something combined? Or there are patients you live with the drops, with the meds?
No, I always want to try something. It might be phaco trab, it may be phaco tube, it may be phaco zen, maybe phaco in focus or PreserFlow or phaco MIGS, depending again on the target pressure and whether the patient's controlled or not. But I always look at the opportunity to get patients on less medication, and I firmly believe that when you combine something with phaco, you get a better reduction in medications. And I think that is something that at least some of the bigger studies, mind you, most of those are with stents, has shown. And I think stents and GAT are probably similar, but stents have less IFEMAs. And they cost more.
Yes.
Yes.
And you have to manage with the patient because we are used to have a very good post-op after only phaco.
Yes. Yeah, I mean, if you do phaco plus GAT, there is a risk you could have IFEMA, yes.
Yes.
And you have to manage that. That's one reason why I like to combine phaco if I can with stenting, depending on other factors perhaps, but that's one thing that I don't have to worry about IFEMA with stents. I mean, it's really, really, really unlikely.
Mm-hmm. Well, I think that one more question and we can finish. Maria Gabriela Izaga is asking, do you perform ECP?
We do. We don't use it typically to reduce aqueous production in open angle glaucoma. We typically reserve it for angle closure to change the position of the ciliary process in plateau iris, like we call it endocycloplasty, described by Dr. Varma. And so I'm kidding. And so, but I think it's an interesting idea to perhaps either combine ECP with GAT to get maybe lower pressure or use it alone. I find with ECP though, to get a meaningful drop in pressure based on aqueous production, you have to do a lot of ECP. You can't just do a light treatment. You got to really blast the processes and you have to do at least 300 degrees and you have to really paint the processes. And those patients have more inflammation. They have risk of CME. So I just find that ECP has not been as favorable for me. I'd rather do an outflow procedure, like a mixed procedure. And as far as combining it, well, I think the additive benefit of combining MIGS with ECP or let's say GAT with ECP, I don't think is as clear that you get that much of a difference. So in reality, I just haven't done a lot myself, but some people have advocated for it and they said, do ECP with iStents. Do ECP with GAT because you may get more effect on lowering pressure production as well as outflow. I don't know if that's completely true clinically. But I will say, sorry, Guillermo, go ahead.
No.
Oh, sorry. Okay. I would just say, like, listen, I think the one thing I hope that people will do when they listen to this conversation is that every glaucoma specialist should be able to do MIGS. Like, really, if you're not doing MIGS, I will tell you, I think you're outdated. And you can be upset with me for saying this, but I'm telling you the truth. I believe that. Maybe you do one GAT per year. That's fine, but at least you can do it because there's going to be a patient who can benefit from it. And it's good to have it as part of your armamentarium. You don't have to do it on everybody and you be selective, but we have enough experience worldwide and locally that patients can benefit from this procedure. And, you know, people who have mild disease, moderate disease and do trabeculectomy, I think that's asking for trouble. Like, I don't think there's a reason to do trabeculectomy at all in someone who's mild. Someone's pressure is 28 and they are not having cataract surgery and they have mild disease and they're on 3 medications, 4 medications. Well, try GAT first. Like, why rush and do trabeculectomy? That's at least one patient you can save from doing trabeculectomy. And if they fail, well, then you do trabeculectomy at that point in time. So I do think that is something I think that glaucoma specialists should be, and anyone treating glaucoma should be comfortable with and should learn. You're going to have your failures, either because maybe the patient selection wasn't ideal, you didn't know, and we didn't know, or maybe the technique is not yet properly refined. But unlike stenting, stenting requires a lot of skill to put it in perfectly and to find the right location, what clock hour. With GAT, you basically have to be able to know how to make a cut in the angle. You have to be able to place a stitch in a hole. You have to be able to put something in a hole. Hopefully most of you are good at it. And you have to be able to pass the suture in that hole, right? And you have to be able to pull that suture out, know when to pull out, right? So if you can do that, I think you can do GAT.
Okay.
Don't forget.
No, I think really it's very important to keep this in mind and to have these procedures as a possibility to our patients, because we are always thinking about mix that it's expensive and we cannot do it because of that. But if you think about GAT, for example, I think that it's very important to keep it in mind and to think about these procedures. And this was a great lecture. Thank you very much. You gave us so many tips. I think that everybody want to come back to the OR to start doing mix. And well, I think thank you very much. I don't know if anybody wants to add something. Rosario, Guillermo, Álvaro.
Simply thank you again for all the tips.
Well, yes, we have more than 100 people here between YouTube and Zoom. So thank you again for all of you.
Somebody's asking if we are not going to talk about other mix. We asked especially about GAT because of the economic, the low cost, and our concerns about the cost here in Uruguay.
Yes.
Yes, I think that's true, and we will talk a lot about. You can certainly visit our rounds we do at Prism. We talked about other mixed procedures, and I've lectured on this before. Lots of different things to talk about, but the principles are quite similar. Of course, it's just a matter of what specific device you use. And yeah, I mean, and I just want to give you a perspective. I mean, someone asked about procedures. I mean, my fellows probably can answer this one for me too. I mean, on any given day, we probably do more bleb procedures than I do GAT or I do MIGS procedures because our patients need them. So don't think that we are saying MIGS for everybody. Not at all. In fact, I probably am more likely to lean toward a subconjunctival MIGS procedure while others would do MIGS. And I argue with people sometimes. No, I would not do MIGS on this patient. I would do subconjunctival procedure. So subconj in your trabeculectomy is still absolutely important, but there's this subtle portion of patients that can benefit from MIGS that is worth considering. I think that all our fellows have done a great job. I want to thank Tiziana. I want to thank Ala, thank Valentina, thank Jeb for presenting. I think it's good to hear from them as well. You know, I want to thank Uruguay. We did this because we have a nice affiliation with Uruguay. Maria, it was nice of you. You basically organized this, I think, and you brought everyone together. So thank you for doing that. I hope personally, I was supposed to visit Uruguay in December, so
yes,
we'll still see if that happens or not. But
we are looking forward to have you here, everyone.
I hope so. Then I'll get high on mate. Okay, I'll get like high on mate.
Well, thank you very much. Thank you, everybody, and hope to see you soon.
Thank you for having
guys.
Everybody.
Well, be safe.
Be safe.
It was a pleasure.
Gracias.
Ciao.
Ciao.